Before I start the class, I will share with you 3 pictures that I find is very good regarding the previous topic in the last class about the anatomy of the skin. So basically, if you see the picture, this is the normal picture of a skin. You can see the hair follicle bulb, the hair follicle melanocytes are there. We have the melanocyte stem cells here, the hair follicle, the hair shaft, inner root sheath, the outer root sheath, the sebaceous gland, we have the keratinocytes, we have the melanocytes, epidermal melanocytes are there. And keep that picture in mind, and this is another picture of all the stages of the hair. The picture is self-explanatory. We have the telogen phase, the anagen phase, and the catagen phase. As you can see, the telogen phase, the hair is becoming just coming out. We have the growing phase in the anagen. There is no hair in the telogen phase, and in the catagen phase, the hair goes up. See, it is shrinking. Okay. One more picture I will show you. This is the growth cycle of the hair follicles. The telogen phase, the anagen phase is the growing phase, and the catagen where the hair is removed from the hair bulb. So these pictures, if you draw in your exams, it will be self-explanatory, and it will be better for you to explain it through the pictures. Anyway, coming to today's topic. Today's topic will be about leprosy. Okay, leprosy. Now, if you go through your questions, mainly we will have lot of questions from leprosy, mainly the lepra reactions. So the leprosy is a big topic, and I will divide the whole class leprosy into 3 classes. Today basically I will go through all the bacteriology, how to examine, and what are the clinical signs and symptoms of the leprosy. Okay. Now coming to the theory. What is leprosy? Leprosy is a chronic disease caused by Mycobacterium leprae. It is infectious in some cases and affecting the peripheral nervous system, the skin, and the subtle other tissues. Obviously, by the name itself, you can see Mycobacterium, so it's related with Mycobacterium tuberculosis. So the treatment also will be similar to that of tuberculosis, but lesser dose, because Mycobacterium leprae is much less infectious than Mycobacterium tuberculosis. What is epidemiology? WHO have told that India previously there is no new case of leprosy, but we have found out that a lot of new cases of leprosy is spotting out in India. It is not at all eradicated, nor it is controlled in India. In my private clinic, I see around 5 cases of leprosy every month. 2 to 3 cases, new cases, and few old cases also. Now, it will seem that children are more susceptible for the disease. Incubation period around 2 to 7 years, usually 3 to 5 years, slowly progressing. The mode of transmission is not yet known for certain, and 3 possible routes are under consideration, like the skin, the GI tract, and majorly the respiratory tract. Anterior end of the inferior turbinate is a possible site of entry of Mycobacterium leprae, and add to that nasal mucosal damage from the common cold may be a facilitating factor. What are the general considerations? It is dangerous to others if any arise from the leprosy patient under treatment, but from the undiagnosed cases. Understand that when we will talk about the treatment of leprosy, the first dose of reformed patient usually cures around 99% of the leprosy patients. But it will kill the 99% of the lepra bacilli in the body. That 1% of the bacilli that remain in the body takes around 9 to 12 months to get rid of. Still, there is one more term called as persistence, which means in the bacilla is still present in the body even after the complete course of treatment of 12 months of a leprosy patient. Now, what are the other causes? Other predisposing factors that are bad hygiene conditions, inadequate food, domestic overcrowding, particularly the night, undernourishment, all these attribute to the better conduction of the leprosy from one patient to another. What is the disease? The disease is the Mycobacterium leprae, which is an obligate intercellular mostly found in the macrophages, which are also called as within the Schwann cells of the nerves, found also in the muscle cells and in the lining epithelial cells of the blood vessels, melanocytes of the skin and chondrocytes of cartilage. It is an acid-fast bacilli, and its smears are treated with pyridine, and the bacilli loses red color, which is known as pyridine extravillati. You will read all this in microbiology better. Now, this is very important. Bacteria indices. When we test a leprobacilli through slit skin smear, we examine the slide under the microscope, and we categorize the patient as 6 plus, 5 plus, 4 plus, 3 plus, 2 plus and 1 plus. So 6 plus means we see lots of bacilli in an average field of a microscope, more than 1000. If it is 100 to 1000, we call it 5 plus. It is 10 to 100 bacilli is seen, that is 4 plus. 1 to 10 is 3 plus. 1 to 10 in 10 fields is 2 plus, and 1 plus is 1 to 10 bacilli in 100 fields. This can come as a short note for you. In lepromatous patients under treatment, it is will be found that there is no fall in the BI during the first 12 months, because the dead and living bacilli are all counted in bacteria indices. We can make out whether the bacilli is alive or dead by looking at the microscope, because a dead bacilli will be fragmented and it will not be a straight bacilli. That will be found mainly in if you see a live bacilli. But after 5 to 10 years, we will see a steady fall of the bacilli index. Now, this is a better indice, which is the morphological indice and index, and it is a possible of a solid stain bacilli, which is the live bacilli, and it is calculated after examining 200 wet staining elements lying singly, and in a knowledge of the index will tell if the patient leprosy is active or not. Now, I am jumping to all these things, but I will explain everything properly when we see a leprosy patient. Now, leprosy patient mainly will see there will be lot of patients will come with hypopigmented anesthetic patches all over the body, 1 or 2 patches all over the body, anywhere of the body. Now, it is mainly sometimes we will see reddish nodules also, or multiple plaques or hypopigmented patches. Now, if you go to the leprosy itself, the leprosy disease is divided into 5 parts. It starts from the tubercular leprosy and ends in lepromatous leprosy. Tubercular leprosy, borderline tuberculoid, mid, then borderline lepromatous and lepromatous. So this is the least number of bacilli in the body, that is called tubercular leprosy. Only 1 patch is seen. And in this it is lepromatous leprosy, where we will see multiple patches on the body, in the skin. So this in tubercular leprosy we see a big, well-defined patch, hypopigmented, hypoanesthetic, or hypoanesthetic means there will be less sensation, or there may be distorted sensation, or there may be fully anesthetic patch. So because it is one lesion and it is well developed, because the body immunity fights against the bacilli better, so we will see a well defined and properly demarcated lesion in the skin. As we go from tubercular leprosy to lepromatous leprosy, we will see multiple small ill-defined plaques or patches in the body, which are mainly anesthetic or maybe hypersensitive due to some reaction pattern going on. So these are the 5 stages: tubercular leprosy, mid-tuberculoid, borderline tuberculoid, midline, borderline lepromatous, and lepromatous leprosy. So mainly we will see patients in the mid-borderline, mid-tuberculoid or mid-borderline lepromatous. These are the main spectra of the leprosy that we see. We very rarely see frank lepromatous leprosy, where the whole body is covered with lesions. Now we have a SFS index in which the bacillus is divided into three classes, that is solid, fragmented and granular. Solid will divide to live bacilli. These are all the dead. The current WHO advice on skin smears in leprosy is that the number of examination sites should be limited to the essential minimum, since all skin piercing methods have the potential risk of transmitting HIV infection. Now, what is skin smear? While I will teach you the testing of the lepromatous leprosy, I will go in detail about the skin smear that we do in lepromatous leprosy. For now, just read this and I will explain it in the later classes. Now, lepromatous leprosy bacilli have a prediction for neural tissue, and where whatever may be the route of entry into the nerves, the target organ is the Schwann cells of the nerves. Once bacilli have been engulfed by the Schwann cells, their subsequent fate and the type of leprosy depends on the resistance of the infected individual. Resistance is highest in tubercular leprosy and diminishes throughout the borderline spectrum, and is lowest in the lepromatous leprosy. Not only do leprosy bacilli have a prediction for nerves, but they are the only bacteria that have the capacity to enter the nerves. It is suspected that they do so via endoneural blood vessels. The nerves invaded by leprosy bacilli are either dermal nerves or nerve trunks, and the two regions which are the most vulnerable are where the nerves are most cool and where they are subject to trauma. Often these two factors coincide. Now coming to the different parts of the leprosy. First and foremost with the tubercular leprosy. The bacilli which enter the Schwann cells multiply within them and slowly destroy them. The process is slow because of the 12 to 13 days that is taken by each bacillus to divide into two. So from one bacilli to divide into two, it comes around 12 to 13 days. Slowly growing bacilli. That's why you say have a long incubation period. The bacilli liberated by the Schwann cells enter neighboring Schwann cells, and thus the interneural infection spreads. But a stage is reached where the interneural infection is recognized and the nerve is invaded by lymphocytes and histiocytes, mainly macrophages, and they become fixed epithelial cells, and the group of these becomes giant cells, and they fight against the bacilli. About 30% of the sensory fibers must be destroyed before evidence of the sensory impairment can be seen. That is mainly hypoanesthetic patch. Histopathological examination consists of epithelial cells at the center with a surrounding zone of lymphocytes, that is round cells. The giant cells are sometimes present among the epithelial cells. Now we have the borderline leprosy. The cellular response is less focal and the less destructive, and the microscopic examination reveals zones of epithelial cells adjacent to the areas of bacillated Schwann cells. In borderline tubercular leprosy, there is an epithelial cells granuloma which is more diffuse than the tubercular, and the narrow papillary zone is seen. The giant cells tend to be of foreign body type rather than of the lamellar cells, and dermal nerves are moderately swallowed by cellular infiltrate and may show only Schwann cell proliferation. The bacilli is usually absent from the dermis, but a few are likely to be found within dermal nerves. In mid-borderline, that is the in-between, BB, it is denoted as BB. There is a diffuse epithelial cell granuloma with scanty lymphocytes and no giant cells. The papillary is clear and dermal nerves show slight swelling and some cellular infiltrate. This is the in-between zone. In borderline lepromatous leprosy, there is a macrophage granuloma in which some of the cells may show slight foamy change. The lymphocytes are present in dense clumps, are widely distributed in parts of the granuloma, and few epithelial cells may be seen. The papillary zone is clear. Leprosy bacilli are plentiful, distributed singly or in clumps, and sometimes in small globi. The bacilli masked with distended macrophages. Now we have the extreme cases, that is the lepromatous leprosy, where the bacilli which multiply within the Schwann cells and perineal cells, there are these who are liberated and the cells are destroyed. The complete destruction of the cells occur in leprosy, and the bacilli are liberated into the surrounding tissue. These cells are engulfed by the histiocytes, and instead of destroying them and becoming fixed epithelial cells, they become as wandering macrophages because they are unable to kill the bacilli because the immunity of the patient is much less. These allow the bacilli to multiply within them while traveling to other parts of the nerves and to other nerves and tissue via blood, lymph and tissue fluid. These swollen macrophages packed with bacilli are known as lepra cells, also called as Ghosh cells. And the muscles of the bacilli which accumulate in the cytoplasm are called as globi. So this is important, and the lepra cells or the Ghosh cells are important. And these are mainly seen in the biopsies or the slit skin smears. The tissues which bear the brunt of the disease are the nerves, skin, eyes, reticuloendocrine system, including the lymph nodes, liver, spleen, bone marrow, mucosa of the mouth, nose, pharynx, larynx, trachea, endothelium of the small blood vessels, involuntary muscles such as erector pili muscles and the dartos muscles, the voluntary muscles of the skeletal muscles, and in the male, testes. We have atrophy of the testes in lepromatous leprosy. As regards the nervous system, the bacilli may reach the posterior root ganglion and the sympathetic ganglion, but are not found in the spinal cord or the brain. So this is not important. We have a mild, and we can have mild anemia. We have increased prothrombin time. The sudden test of syphilis can show false positive, and test used for the identity of autoimmune disease can be positive in some cases. Coming to the clinical signs and symptoms. Leprosy is considered one of the mimickers of lot of diseases. We have an enormous wide variation of the way the disease involves only one peripheral nerve, a mononeuritis, or causes a single skin blemish which persists indefinitely or disappears on its own accord, mainly seen in tubercular leprosy. While in others it produces countless nodules, and other countless nodules are mainly seen in lepromatous leprosy, LL. Together with polyneuritis and damage to vital organs such as eyes, larynx, testes and bones. It is worth remembering that a combination of skin and neural tissue is strongly indicative of leprosy, and the correct diagnosis can usually be made with the help of pin and a scalpel. Now what happens is that you have a lesion of leprosy here in a forearm. So what is the easiest way to diagnose is that if you feel the surrounding area or the same spot in the other side of the body, and then touch that area and ask the patient whether they can feel the same sensation or decreased sensation, the patient will say that they are decreased sensation. Sometimes in reaction patterns, the sensation may be increased, but definitely it is not the same sensation that we will feel in the other parts of the body. Now, and what are the else? What else? Because of the destruction of the hair and the surrounding tissues and the other organelles, we will have less sweating in that area. We will have destruction of the hair follicles and the hair, loss of hair in that lesion. And the skin will look little bit shiny. So mainly we see a shiny area part in a hyperanesthetic, hypopigmented patch over the body, which will have decreased sweating and decreased hair, skin hair in the lesions. Now that is the help of the pin is to find out the sensation. Now for the patient there are two types. Some of the dermatologists, they ask the patient to close their eyes and ask to feel. Now whatever the patients are always a little bit more intelligent, no. Without even touching the lesion, the patient will say that, yeah, I can feel it, I can feel it. Because everyone has the apprehension in the mind that they will be a patient of leprosy, because we have a social stigma against leprosy. As we know, we have gone through the history, Indian history, we know how Mahatma Gandhi treated leprosy patient and how it was considered a social stigma all throughout the history of India. Now, we can ask the patient to close the eyes and we'll press that area of the skin, we'll press different part of the skin and ask the patient whether they can feel it or not. Or we can use a pen and slowly draw a line which will go around the lesions also. And we'll ask the patient whether the sensation is same throughout or it is lesser in the lesion and higher in the surrounding normal part of the skin. That is the patient will reply in the affirmative. Sometimes we will ask the patient to open their eyes and themselves tell if the patient is intelligent and is an educated patient. We ask the patient, see, I am touching the needle, just say whether the sensation is same or the different. That's how we check. Now, why is the scalpel used? Scalpel is used to do the slit skin smear. Now, what is slit skin smear? Now, what happens is that we will take certain areas of the skin, body, mainly the ear pinna or the forehead or any of the lesions in the body. Now, what we'll do, we'll first pinch that area for 20 seconds until the area becomes almost white and it is drained out of the blood. Then we'll take a size 15 scalpel blade which will be curved and we'll just slit the skin. The depth of the slit should be around 3 millimeter by 2 millimeter. 3 millimeter in length and 2 millimeter in depth. And once we make the slit, we'll turn the blade in 180 degree and then remove the serous fluid from the lesions. Remember one thing, blood should not contaminate the serous fluid. We'll take the serous fluid, make a smear on top of the glass slide and do a modified Janssen stain for that, and we'll find out whether the patient has lepra bacilli after seeing it examined in the microscope. Now, basically 7 sites of the body is checked. Both the earlobes, forehead, nasal septum, both the nasal septum. Now, in the nasal septum, we will not use a scalpel, we use a nasal speculum to take the smear from the nasal septum. The lesion should be involved, one side will be from the lesion itself, and we can use any of the forearms or the legs, depending on which nerve of the body is involved after we check for anesthesia and the nerve thickening. That expression, when we show you a leprosy patient, we will show you how to do the slit skin smear and we will tell you in detail when we will teach you in practical. Now, it is unusual to have the opportunity to examine a patient in the early stage of leprosy as there is no symptoms of nerve involvement and early and skin lesions are not likely to be noticed by the patient. This is because we will get the nerve involvement mainly when the body actually fights against the disease. But in leprosy, the immunity is so less, the body will not fight against the disease and therefore the symptoms will be much lesser. What is the more unfortunate is that it is not only very infectious and there is a potential danger to the public health, but is missing the opportunity of the disease arrested in the shortest possible time and to remain asymptomatic. The two symptoms which can alert the observation are the nasal symptoms, mainly epistaxis, bleeding from the nose, because the nasal turbinate is the first part of the body that is involved, and there may be edema of the legs. What are the nasal symptoms? Consist of stuffiness of the nose, casting formation and blood-stained discharge. Edema of the legs and ankles are always seen, always bilateral and likely noted to the end of the day, disappearing after night rest. As for skin manifestations, the patient may present with macules, papules, nodules or all three, but macules are likely to appear first. Remember, these are all in the lepromatous spectrum of the disease where the lesions are more prominent. The skin lesions are multiple and have a distribution which is bilateral and symmetrical. Although face, arms, buttocks and legs are principally involved, the trunk may also be affected. Certain regions of the skin which have the highest temperatures are invariably spared, such as the axilla, groins, perineum, hairy scalp, thus conforming to the general rule that the leprosy bacilli favor cooler temperatures of the body. The macules in lepromatous leprosy are erythematous in light skin and on dark skin are coppery or may appear hyperpigmented with a faint erythematous or coppery sheen. They are difficult to see but become more obvious when the patient becomes heated and after exercise on a hot day or after a hot bath. They are small, numerous, have a shiny surface and vague edges and show no loss of sensation and or of hair growth papules and nodules which may have normal skin color or may be pigmented, usually erythematous or in coppery color, are formed on palpation and are in the skin and not in the subcutaneous tissue. The nodules show a great variety of sizes. When a patient presents with all the three types of skin lesions, usually nodules are on the face and limbs, macular lesions are mainly seen in the trunk, which is less involved. Now, thickening and nodulation of the both ears are the early development. Mainly for leprosy patient, we will always check the ear pinna for any thickening or nodule formation in the ear. And if there is nodule formation of the ear, it is better to take the skin smear from those nodules. The skin of the face becomes generally thickened, the nose becomes swollen and broadened, eyebrows become thin, superficially madrosis, together with eyelashes, that is called as ciliary madarosis. Untreated disease advances to thickening of the skin and forehead causes deepening of the nasal lines, which is called as leonine faces, like a tiger. The face becomes more like a lion, not a tiger, lion. The ear lobes are thickened, the eyebrows are lost, the nose may collapse because the nasal septum gets destroyed, the voice becomes hoarse, the upper incisor teeth loosens and falls off, and bilateral insensitivity of the limbs, known as glove and stocking anesthesia, is there and leads to shortening of the fingers and toes due to painless and often repeated trauma. Now, what happens? Mainly the hands and feet are involved, the anesthetic areas. So, we have the glove and stocking anesthesia. Now, once there is no nerve sensation in the hand, the patient will not be able to differentiate whether there is a lot of trauma or not. There are a lot of patients of leprosy who comes with superficial burns in the skin. Sometimes they hold a hot tea in the hand and they don't feel the temperature. Now, in leprosy patient, the temperature sensation is the first thing that is gone. So, sometimes they hold a hot tea, a cup, and they get burns. We had a very interesting case during my PG days. One of our patients of leprosy undergoing treatment in our hospital always used to have blisters in the hand. Once we treat the blisters, after a few days, the blister will reappear. Now, everyone, because he was not allowed hot tea and nothing, so all of our teachers and all the postgraduate students were confused as to where the blister is coming. So one day I arrived at the hospital very early and I saw that the patient goes to the temple in the hospital in the morning and takes blessing from Lord Ganesha. And he puts his hand very near to the lamp and takes blessing. So that's how he gets blisters, because he is not able to find out whether the temperature is very hot or not. And he puts his hand near the lamp and then take blessing, and that results in blisters in the patient every day. Now we have one more thing, that is ichthysis, that is dryness of the skin, that is CP affects the thighs, legs and arms may also be affected. We have nerve thickening and associated sensory and motor neuron dysfunctions, and depending on the type of nerve involved. The thickened nerves feel firm and smooth. Thickening becomes localized to the portion of the nerves which are most superficial. The great auricular nerves in the nerve neck, the supraclavicular nerves as they cross the clavicles, the ulnar nerve just above the elbow, the anterior brachial cutaneous nerves in the forearm, the radial and medial nerves at the wrist, the femoral cutaneous nerves, the lateral popliteal nerves, the sural nerves, the posterior tibial nerves, the superficial peroneal nerves. The limbs are tested for the sensory impairment like light touch, pain and temperature and other things. All the modality of the sensations should be tested, as sometimes only one is affected. The nerve domain is mainly bilateral and symmetrical, sometimes maybe unilateral also. Loss of the warning sensation of the pain leads to repeated injuries in the hands and feet, and chronic plantar ulceration is one of the chief problems in management of the leprosy. Anesthetic skin is particularly liable to blister when exposed to heat. Damage to motor nerves are shown as muscle weakness, muscle atrophy. The affected muscles become wasted and paralyzed. Muscle difficulty affected as those suffered from the facial nerve can lead to facial palsy, ulnar nerve can lead to claw hand, median nerve can lead to ape hand, and both ulnar and median nerves can be involved. Lateral popliteal nerves may lead to drop foot, and posterior tibial nerve may lead to claw toes or hammer toes. An enormous number of leprosy bacilli will be found in the skin. Now this is a picture of a leprosy. Few papules are seen in the only component of the patient. In the hand we can see shiny wrinkle of the inflamed skin of the leprosy, and we see the hair losses. We have the nodules in the ear. We can see these are the big nodules. See in the ear, nodules. See, these are nodules of a ear involved in leprosy. This is a pure orange appearance of the chest with gynecomastia due to the activity of the testis in leprosy patient. These are the histoid nodules of the buttocks of a leprosy, histoid leprosy. Rest all pictures and everything we will show you in the next class. Okay, thank you. I think hopefully you will have an interesting class. Very interesting case. It is very difficult to diagnose a leprosy patients nowadays, but once we have seen a few cases in our hospital, and we will show you leprosy case patients to you. Thank you.